1160. It is so good to welcome Dr. Dan Clark back into the studio, Indiana Regional Medical Center, as we talk about colon cancer and Colon Cancer Awareness Month. We do the weekly series of features at 8:10 each Wednesday morning. Dr. Clark, good morning to you. Good to have you back.
Good morning. Good to be back.
It's good to have you here. Our conversation brought to you by Marcus and Mack, a law firm representing injured people. Colon cancer, those statistics can be pretty scary. If you let this thing get too far along.
Right. When you look at the incidence of colon cancer, everybody understands with breast in women is the number one diagnosed cancer, and prostate in men is the number one diagnosed cancer. However, colon cancer is actually the second leading cause of cancer deaths in both men and women in this country and across the world, actually, too.
That's amazing to think about. But it is something that is eminently treatable, and as we say in the commercial, very beatable.
Right, and preventable. And that's the big thing is that, when you look at the incidence, it's a number 3 cancer in the country behind. For men, it's prostate, then lung still, and then colon. And in women, it's breast, and then lung, and then colon, with lung being the leading killer and colon being number 2. But with early detection, we can get it before it's ever cancer and remove it.
Yeah. So let's talk about how that happens. First of all, what is early detection and how is that done?
Right. There's several different ways for early detection. The old, doctor sends you home with some stool cards, essentially called the fecal occult blood test. Mm-hmm. The unfortunate thing about that, it's affected by a lot of things in your diet that can make it positive and some things that can make it negative. If you take too much vitamin C, it can make that, false negative. If you eat red meats or spinach or things like that, it can turn it to be positive when it's not. It also is not real good at detecting about half the cancers in the colon. It's better at cancers from the left side and not from the right because it detects blood in your stool, and the blood from the right side of your colon can be processed before it's eliminated. And so the fecal occult blood test is not as good anymore. It's not really one of the recommended spots. It's still done. It's better than nothing. And, it's a good screening, but it's not really what you want to do.
Served its purpose in its time.
Absolutely.
But we've advanced beyond that.
And now they have these FIT tests. It's fecal immunoassays, where they actually have immunoglobulin assays for blood in your stool again. Mm-hmm. And it's better. It's more sensitive. It picks up more blood in the stool. But again, not all cancers secrete blood in the stool, and again, it's not as good with right-sided as well.
Yeah. So for you and for everybody else in the medical community, the colonoscopy is still number 1?
Absolutely. Yeah, and a matter of fact, if all these other tests show anything, guess what you need? Colonoscopy. And both the American Cancer Society, the U.S. Preventative Task Force, all the American Society of Gastroenterologists all recommend the colonoscopy as the prime screening tool in this country.
And a couple of years ago, they lowered the age at which they recommend that you begin to get your yearly, or it doesn't have to be yearly, colonoscopy.
Right. It used to be age 50. And if you want your average risk, that's no family history, none of the other risk factors associated with an increased incidence of colon cancer, you should get a colonoscopy at age 50. We're seeing, unfortunately, younger and younger people with colon cancer in this country, and that's been a trend for many years. And because of that, we are also seeing higher death rates in younger people because it wasn't diagnosed early. And so we actually had lower mortality if you were older when you got colon cancer than if you were in your 40s. And so the recommendation now is if at age 45, if you have no other risk factors, so this is just the average person, at age 45, you should have a colonoscopy done.
Okay. And for folks who don't know, what does that colonoscopy look for? Obviously, scope means you're taking a look at,
right,
and you're actually going inside the body to do that. What are you looking for?
Yeah, just like you say, it's a colon scope. Pass a video scope up the colon, and you're actually looking for polyps. Because cancers in the colon, the vast majority arise from colon polyps. They're precancerous polyps. They're called adenomatous is one type, and another type is called a sessile polyp, and they account for the vast majority of colon cancers. So you're going up to look for a polyp. And in average people who have a colonoscopy, 30 to 40% will have a finding on colonoscopy as far as a polyp is concerned, but only 0.5% will actually have cancer. So you're taking these polyps out before they become cancer. So that's what we're hoping to do with colonoscopy. And then you never need to see somebody like me because it's been removed at a polyp stage, a precancerous stage.
Yeah. And so prevention is such an important part of the whole riddle when it comes to colon cancer. If prevention doesn't catch it, if the colonoscopy comes too late, if somehow colon cancer does develop, tell me about treatments.
Well, the main treatment, of course, for colon cancer is surgery. But the good news is that although our incidence is increasing in younger people, our overall mortality or death rate from colon cancer has been gradually decreasing since the 1980s. And that's because of advancements in treatment. Not just surgery, but also the non-surgical treatments. The chemotherapy. Nobody wants to hear the word chemotherapy. I hate that word because it has such negative connotations. And it really should be medical therapy for cancer. And that involves far more than the typical chemotherapy agents. We now have immune therapy that I've seen some amazing things happen with immune therapy with colon cancers that have been resistant to traditional chemotherapy. But hopefully you won't even need that. If you get a colonoscopy and you find an early cancer, we go in and take it out, and we can essentially cure you of it at that point.
Yeah.
So.
And I think that's something for people to understand as well, is that when you have the scope and you're taking a look inside the colon, that is when the polyp is removed, when you encounter it.
Right. So they remove the polyp, and if it's not, cancerous or, there's some really high-grade polyps, which they find about 10% of the time that may need a little section of colon removed because of it. But the vast majority are the precancerous. They remove them. You don't need anything else done, except if they do find polyps, we recommend a colonoscopy in another year to make sure there's no others or that it was completely removed as well.
And I know that you are such a great practitioner of robotic surgery. If that surgery becomes necessary, you do have to remove a portion of the colon. Because of the precision of the technology now, you're able to greatly reduce recovery time, the actual incision. All of those things are now much, I don't want to say easier, but certainly much more able to get somebody on the road to recovery quicker with less complications.
Absolutely, and that's the beauty of the robotics is that we can do 3 or 4 dime-sized incisions and put the instruments in, and we control them with the robotics with wristed instruments now. So now I have little hands in there essentially that I can reach around things and tie things, and plus we have 10 times magnification with a camera for each eye through the robotics, so I get depth perception and 3D vision. So now instead of, I actually just reviewed all this information for Indiana, and back in 2016, pre-robotics, the average length of stay was 9 days in the hospital for colon surgery, and when you had to have an open operation. The average length of stay now, since we do all of these robotically, and my partner's doing robotically as well, is 2 to 3 days in the hospital now with far less pain. Most of my patients do not even require narcotics because we have a non-narcotic pain regimen, and you don't have as much pain with the smaller incisions.
Dr. Dan Clark is our guest. We're talking about colon cancer, catching it early. If we don't catch it early, treating it, and the number of options available there. Let's talk about prevention of colon cancer. Are there things that we can be doing in our daily life, in our diets, or in some other way that are going to help us to avoid a higher risk of falling victim to colon cancer?
Absolutely. One of the big risk factors for colon cancer, and actually a lot of cancers, is obesity. And so being overweight puts you at higher risk for colon cancer. There's some things we can't control, such as our race. Black individuals are at higher risk, and Asian individuals are at lower risk. Men are at higher risk than women. But eating a low-fat, high-fiber diet is another one. Limiting red meats. I love a good steak. Don't get me wrong. And I love sausage and bacon, and I'm like everybody else out there. But moderation and trying to limit those, because those have actually been shown to increase your risk of colon cancer. So a diet high in red meats or processed meats, lunch meat and things like that, have been shown to increase the risk of colon cancer. An aspirin a day actually has been shown to decrease the risk of colon cancer.
Yeah.
That was a side effect from the heart studies when, they were saying an aspirin a day to decrease the heart, and that's come under some question now. And one of the side effects that came out of that is we saw lower incidences of colon cancer, and that's been looked at. And it's pretty good data. There are some controversies among it, but it's pretty good data that an aspirin a day will decrease your risk of colon cancer.
How about that?
Now, before you go on aspirin, I don't want to tell everybody to go on aspirin because you maybe have other issues that you shouldn't be on aspirin. Sure. You should discuss that with your doctor first.
Yeah, absolutely. Okay, so you and Dr. Billen coming up next week. You've got a program coming up just up the street from here.
Right. Yeah. And it's Colorectal Cancer Stinks. And so
who came up with that title?
I don't know, but I think it's a pretty good one.
Yeah.
So, it does in many ways. And so it's right up the street here.
The Philly Street Candle Bar.
Right, the Philly Street Candle Bar. You have to go on the website to register for it. There's still a limited number of spots available. Dr. Billen and I will be talking about the advances in colon cancer treatments. And you can actually make a candle while you're there, too.
There you go. There you go. So the number to call is 357-7188, or you can go to irmc.org/2022. It's $5 per person to cover the cost of your materials to make your candle. And then the presentation begins at 6 p.m. with Drs. Clark and Billen. So that is coming up. When you think of colon cancer, the one area that I don't think we covered as well as we should is women, men. Is one more likely to get colon cancer than another, or is it a pretty just evenly spread thing?
Well, like I said, it's the third most common cancer in both men and women. So it's common in both. Men have a slightly higher risk, but I don't want women to think that they don't have a risk. It's the third most common cancer in women. It's breast, lung, and then colorectal cancer. Yeah. And so both are at risk for colon cancer.
So having heard at what age we should begin to think about getting our colonoscopy, first visit is to primary care physician, right?
Right. And primary care physician, and actually, there are people whose insurance do not require a referral. You can call the gastroenterologist's office. I personally no longer do scopes, but my partners do. Dr. Billen, Dr. Guidetti, Dr. Walkowski, our new partner, do it. So, those are things. And a little plug for the bariatrics. If you're morbidly obese, you have a higher risk of colon cancer. Those patients who undergo bariatric surgery or weight loss surgery actually reverse that risk. And they decrease their risk of colon cancer. That's another benefit of bariatric surgery as well.
Tremendous stuff. Tremendous. Okay, so once again, for the event coming up on Monday at the Philly Street Candle Bar, which is at 8th and Philadelphia Streets, it's at 6 p.m. The number to call is 724-357-7188. And the website is irmc.org/2022, and you can register right there. Dr. Clark, thanks so much for coming in.
Oh, you're welcome. I'll be back later this month, I guess, and we'll touch on some things. As you know, one of the things close to my heart is genetics with colon cancer.
I know. I was going to get into that with you today, and I know that's a conversation that it does take almost a whole segment just for that, because it's as fascinating as can be.
So that is one of the main risk factors for colon cancer as well.
Yeah. All right. Dr. Dan Clark from IRMC visiting with us this morning.